I am Venanzio Vella, working as an epidemiologist and a health economist at Imperial College, and I will show the use of three indicators of bed utilization that are sometimes not fully understood, like bed occupancy, bed turnover, or average lengths of stay. The idea is to use simple indicators graphically in order to pinpoint an area where efficiency may be a problem, and also visualize where efficiency can be related with other indicators of impact, like hospital care-acquired infection. In this case, I will talk about the efficiency and the Clostridium difficile infection rates. So the outline is, besides the objective, the rationale, the method, the results, and the conclusion. The objective, as I was talking before, is to visualize the indicator of efficiency in order to allow managers to immediately spot problems in the hospital versus other hospitals, and also to identify a critical cutoff point for these indicators of bed utilization that are strongly associated with healthcare-associated infection. The rationale is that bed utilization influences the hospital efficiency because as a high fraction of hospital costs are fixed, we need a lot of patients to be churned out in order to reduce the cost per patient. On the other hand, a balance needs to be struck between the efficiency and the risk of healthcare-acquired infection. Like if we increase occupancy at a certain level, we can risk to increase hospital care-acquired infection. So there is a need to strike a balance between efficiency and adverse events. And then the bed utilization can be also a good combination between a management tool to increase efficiency and also a tool to control healthcare-acquired infections. The method, this was a retrospective study on the NHS English Trust between 2013 and 14. And the Pablo-Lasso charts, I don't know if anybody know about Pablo-Lasso charts. Okay, the Pablo-Lasso chart I will show is a nice method to visualize the occupancy and turnover and average length of stay. So this was the Pablo-Lasso chart that I used. And then I did a multivariate analysis in order to find out the relationship between bed utilization and healthcare-acquired infection, especially Clostridium difficile infection rate. The indicator of healthcare-associated infection in this NHS trust were the reported CDI rate, and these are more reliable because they are performance indicators, and therefore we assume that better reflect healthcare-associated infections. Only trust apportion reported cases were considered, so those that are related to specimens with date on or after the first day of admission, to ensure that they were more related to the infection within the hospital. As we know, the annual patient flow, this is just a quick way of looking at the three indicators. Not many people are using, for example, bed turnover rate. Basically, the annual admission produces certain lengths of stay. This cumulative length of stay is divided by the total number of beds multiplied by 365, and we have the occupancy rate. Then there are the annual discharges that, divided by the total number of beds, will form the bed turnover rate. So in other words, how many patients turn on a bed like in a year. So if we see the major indicators, we have the bed occupancy rate that are basically the occupied bed days divided by the available beds multiplied by 365 days. The bed turnover rate are the number of discharges divided by the number of beds. And the average length of stay is a % of occupied bed days over all available bed days. So if we look at these three indicators, this is a table, I produce a table as an example. We have on the first, over the first column the occupancy, on the second the bed turnover, and on the third the average length of stay. You can see that this is a quite crowded table, and therefore you cannot immediately spot where the hospital is in terms of efficiency. For example, N3 in red has an occupancy of 94% and a bed turnover of 59% and average length of stay of 5.8 versus Imperial that has a lower bed occupancy of 85% but a higher bed turnover, 76 patients per year, and an ALOS of 4. There is another way to look at this in terms of a Pablo-Lasso graph. The Pablo-Lasso graph relates two indicators, the bed occupancy here on the x-axis and the bed turnover on the y-axis. Basically, this is the number of patients per bed per year, and this is the average bed occupancy. If you look at N3, is here, while Imperial is here. What this tells is that the hospital cluster in area of difference efficiency, because this area is characterized by both high turnover but also high occupancy. The other interesting thing that you can observe is the average length of stay. These are lines that are from the origin, and because of the relationship between average length of stay, bed turnover, and bed occupancy, each of these points are basically constant. So this is also a nice way to see the relationship between bed turnover, bed occupancy, and average length of stay. You can see the average length of stay are lower in this area, increase clockwise. So what happens is that you may have several hospitals that you can sort of cluster in different type of efficiency. So we can say that in this case, instead of looking at that table before, we can immediately spot where N3 is or where Imperial is. So this is the advantage of the Pablo-Lasso. Not many people use it. What is the problem when we try to link the efficiency with the healthcare acquired infection? The problem is that the percent of admission diagnosed by ICD-10 through diagnostic categories may be different in hospital with longer length of stay. And therefore, there is a problem of confounding. So in the case the patients stay there because he's a frail patient, automatically will be more subjected to hospital-acquired infection, but also to a longer length of stay. So it's important to control for patient mix. This is used usually by the percent of admission diagnosed by ICD-10 categories. I have put in this list also the hip replacement rate per 1,000 admission, because it's also part of the patient mix. The percent of beds which are used for critical care, so more beds used for critical care, more acute patients. And then the number of beds per full-time staff equivalent. So this is what I analyze in this relationship between efficiency and healthcare acquired infection. The data sources were the Health and Social Care Information Center and the hospital episode statistics for the number of admission, ALOS, diagnosis by International Classification of Diseases, and the number of full-time equivalent staff. The NHS England reported statistics for the occupied and available beds, and the Public Health England reported the number of infection from MRSA and CDI. I took the CDI because at the moment the MRSA are quite low. The result. What you can see here is that of the over 181 hospitals that were available with the data in 2013 and 14, you can see how the Pablo Lasso nicely clustered the hospital. You can see that, for example, this is the annual bed turnover rate, number of patients per bed per year. This is the average bed occupancy. I draw this line because they are the line corresponding between the 5th and 95th percentile of BTR and the 9th and 95th percentile of BOR, of bed occupancy rate. So this box basically divides the acceptable estimate in terms of bed utilization from the outliers that are quite scattered and are outside the 5th, 95th percentile. So within this box that is more acceptable because it accepts only values that are within the 5th, 95th percentile, you can spot two clusters. One is a cluster of acute hospital that has basically an average length of stay between 3 and 6. And the other is another cluster of more chronic hospital with an ALOS of more than 10. So you can already see the advantage in this picture because it gives you immediately two clusters plus the outliers. What happened is that when I analyzed the burden of disease in these two clusters of hospitals, in the first hospital of acute trust, 92, you can see that there are the use of chronic degenerative diseases, but very few 1% psychiatric disorders. Instead, in the other group, the more chronic one, 44 NHS Trust, we can see that psychiatric disorders are almost half of the burden. And this explains why they are long-term stay hospitals. Now, the CD rate in NHS acute hospital, I took only the acute hospital in order to reduce the confounders. The CDI rate in NHS acute hospital, basically, what I wanted to ask to the analysis is, what are the thresholds of bed utilization that are associated with a higher risk of CDI rate? Is this a causal association or a spurious association because frail patients can stay in acute hospital longer and therefore there may be a confounder? So what I did is first I correlated the CDI rate on the y-axis per 1,000 admission with the BTR in the x-axis. You can see that there is a declining line, means that increasing rate of turnover associated with a decline of CDI per 1,000 admission. The same is in inverse direction between the CDI and the bed occupancy rate. You can see these are hospitals, these points. You can see that there is an opposite direction in which, with the increase of occupancy, the CDI rate increases as well. And this is as expected. I applied a linear regression model in order to see if this 92 acute NHS trust could reflect this association between bed utilization and CDI rate. The dependent variable of the NHS trust rate was the CDI per 1,000 patients. The predictors were the quintile for BTR and BOR. In other words, in the percentile distribution of all the hospitals of bed occupancy and bed turnover, I selected as cutoff point the quintile, so every 20th percentile. The percent of admission according to diagnosis due to ICD-10 code groups was also controlled as a confounder. The hip replacement rate of the hospital was also controlled. the percentage of bed assigned to critical care was controlled, and also the full-time year equivalent of staff per bed, because this is a proxy of workload. The linear regression was basically a control for linear assumptions. Therefore, for example, all the residuals were so as pretty scattered around the mean. The tolerance and variance inflation factor above 2 were considered potential risk for confounders and collinearity. And the process was reiterated until the last model contained only statistically significant variable. In other words, I began with all the variables, and I took the variable one by one until only the most significant variable remained. This is the model. You can see here the bed utilization. Again, the dependent variable is CDI rate per hospital. And you can see that the variable on bed utilization are divided in quintile. For example, the bed turnover rate quintile 2 goes between 64 and 72 patients per year, per bed per year. The third quintile goes between 72 and 77 patient per bed per year, and so forth. The same is with the bed occupancy rate. You have, for example, the second quintile going between 82% and 84.5%, the second quintile between 85 and 87%, and so forth. The other variables that were taken into consideration were the patient mix. These are the proportion of admission due to psychiatric disorder, the proportion of admission due to neurological disorder, circulatory disorder. So each hospital basically had a profile with a certain proportion of the burden of disease. And finally, there was the human resources that is quite important because of the workload. This was measured between the number of beds per consultant. So basically, a consultant, full-time equivalent consultant that had a lot of bed was more overload. The same is number of beds per registrar, number of beds per midwifery and health visiting staff, number of beds per technical staff, number of beds per qualified allied health professional, number of beds per qualified healthcare scientists. So we have quite a lot of confounders that we have controlled. What happened is that if you look at the model, this is on the left-hand side, you see all the variables in the initial model. And on the right-hand side, you see the variable that remains significant in the final model. You can see that, for example, the BTR quintile was significantly associated with CDI infection rate, but in a negative coefficient, with a negative coefficient. So in other words, there was a significant lower rate of CDI per 1,000 patients if the hospital was within this quintile. The same with the second, the third quintile, the fourth quintile, and the fifth quintile. These are all compared with a baseline of the first quintile that is, of course, a lower BTR. The same you can see with the BOR, bed occupancy rate, quintile 2 was not significant, but quintile 3, and it started from 84.6%, started to be significant. So you can, let's say, use this as a cutoff point, more than 64, and less than and more than 85 as critical threshold in which the CDI rate increase. So what we can do with this model is basically draw lines on the pabolasso starting with this type of threshold. So if, for example, we draw a line, an horizontal line from the bed turnover rate that is exactly at 64, we can divide the pabolasso into 4 quadrants, one that is at higher risk and the other that is a lower risk. Similarly, we can draw a vertical line starting with 85% of occupancy, and we can divide the pabolasso. By the way, also I want to show that there were other variables in the model that stayed significant. One was the proportion of admission due to digestive disorders remained significantly associated with CDI rate, and also the admission due to pregnancy and childbirth. That was also associated with CDI rate, but in negative term. In other words, if you are admitted in a hospital with more admission with digestive disorder, you have a high correlation, positive correlation with the risk of CDI. If you are admitted, a hospital has a lot of admission for pregnancy and childbirth, they will go away quickly. And therefore, their relationship with CDI is lower because basically they stay less in the hospital. But these were the only variables that were significant in the final model. It's interesting to note that all the human resources didn't reach the statistical significant level. Now, what you can do with this data in a practical operational situation is to give direction to the hospital manager in the pabolasso graph to indicate where are the quadrants that may be more at risk. As I was telling before, if you draw a line starting with the second quintile for BTR, you have an horizontal line, then you have another vertical line that starts with the third quintile for bed occupancy. You have 4 quadrants. The first quadrant is a high bed turnover but low BOR, similar to the situation, for example, of a hospital having a lot of pregnancy. This second quadrant is the most efficient because it has a high BTR, but also a high BOR. Clockwise, this third quadrant is having a high occupancy, but a low turnover, and therefore is potentially more at risk, because exactly is in the situation in which the 2 thresholds are defining the quadrant at higher risk of CDI. The last quadrant, quadrant 4, is characterized by the low bed turnover and the low BOR. So is still relatively at risk, but less. So we can say that the analysis allowed us to get this threshold with a control of the potential confounding factors. So we are pretty confident that drawing these 2 lines that correspond more or less to the traditional cutoff point, 85% of occupancy, and another cutoff point is around 70 per BTR, we can say that controlling for the confounders and using a visual aid for the manager in which you have basically 3 indicators. The first indicator is the annual bed turnover. The second indicator is bed occupancy. And the third indicator, these are the numbers besides the dot, is the CDI rate. You can put, of course, any other type of indicators like mortality rate, other type of infection rate, etc. But what I find quite useful in this sense is a snapshot that gives you the sort of like a dashboard in which you have this graph that first of all tell you where your hospital is, where is the quadrant, and how the quadrant relate to the other quadrant. This is the most efficient, this is the least efficient. This we know is high fast but low occupancy. This is probably chronic conditions because it's more high occupancy and also low turnover. So in conclusion, I think that these three indicators that are not well known because bed turnover rate is not much used can be associated with both length of stay and bed occupancy rate, because consider that here we can put also the length of stay as isoline departing from the origin. So you have 4 indicators in this case. So what I suggest, for example, to your group, that because these, of course, are not your data. I took the data from website. But what could be useful for your group is to start recording the beds, the number of beds, and the available beds, the occupied beds. So you can then use this type of indicators like bed turnover, bed occupancy rate, and ALOS. And then, of course, give this is a sort of dashboard to help manager to immediately spot where the hospital is. So in conclusion, the graph gives a much better representation than tables. If we had to represent all this story in tables, will be a nightmare because it will be table over tables. The BTR less than 64, less or equal than 64 patients per bed per year, and bed occupancy rate higher or equal than 85% can be used to define the threshold for higher risk of healthcare-associated infection to define the quadrants of the Pablo-Lasso graph. The efficiency of the graph can be added to a dashboard because it's pretty straightforward for the hospital manager to monitor the relationship between efficiency and a healthcare-associated infection. Other outcomes like mortality, cost per discharge could be also included. So the nice part of this, I put the CDI rate besides each spot. You can put the cost per equivalent patient rate, and this is a nice correlation visually between the efficiency quadrant and the lower cost, because probably you will have a lower cost in the least efficient quadrant. So I think that this could be quite a value-added representation because it's not the usual statistics. Use multiple regression in order to control for the confounders, and give a rationale to establish these threshold values in order to divide the Pablo-Lasso graphs.